Thank you for that kind introduction. And I just have a few slides to go through to kind of give everyone a feel for where we're at in our research program. And as mentioned, I am the Dianne and Irving Kipnes Endowed Chair in Lymphatic Diseases at the University of Alberta. But before I get started, I want to remember Dianne Kipnes. As many of you know, she passed away over the holidays. And she was the driving force behind this endowed chair, where she wanted to create this basic research position to get a better understanding of lymphedema and its causes, as well as she had an overall desire to improve the lives of lymphedema patients, both by understanding the disease as well as to improve the care that lymphedema patients get in Alberta. The president of the University of Alberta kind of summarized it by saying whenever Dianne saw a space to make a real difference in the world, she would step forward with vision, drive, and foresight. Together with Irv, they've always developed a thoughtful plan to realize their vision to the greater benefit of so many areas across the university, including business, music, medicine, and engineering. So obviously it's a great loss, and but her legacy will live on. Part of her legacy is this lymphedema research program. I established it in 2021, and there's two major goals of this research program. The first goal is to establish a translational research program with lymphedema patients, as well as developing animal models of lymphedema, as well as understanding the molecular mechanisms behind lymphedema. And from that, to answer a specific question that I was interested in and in which many people have asked me, and that is to understand why lymphatic damage in some patients develop into lymphedema, while others, it doesn't happen and they recover quite nicely. Yet they have all the different risk factors, they have the same type of damage. Why do some patients get it and other patients don't? So to try to answer these two focuses of my research program, we made sure that the lymphedema patient is central to everything that we do. So if it's the animal models, it has to reflect what goes on in the lymphedema patient. We also developed a biobank and clinical database where we collect lymphedema information as well as blood samples. And then we take the molecular mechanisms that we think is relevant to lymphedema and then apply it to the patient to say, does this make sense? And our ultimate goal is to try to get to a point where we can then go in and have clinical trials or studies to see if we can make lymphedema patients' lives better. I mentioned the lymphedema bank. Since we started, we now have 70 lymphedema patients' blood samples that have been collected. The majority are breast cancer-related lymphedema patients, but we do have patients who are from the Chris Clinic here in Edmonton, as well as patients who have other types of cancer. We've established an ethical approval now to collect skin biopsies from a plastic surgeon here in Edmonton. And we're hoping in the next year to be able to get some of these specimens. We've also received breast cancer patient samples from the Alberta Cancer Research Biobank. We're right now in the MTA stage in getting these samples. And these samples are from breast cancer patients who got lymphedema and ones who didn't. And this can provide a comparison to seeing what is different between these patients. So in terms of the questions we wanted to ask, one of the questions we were really interested in when we were doing the biobank is where are lymphedema patients? Because to my, or is probably not too strong of a word, but to my surprise, lymphedema patients are really hard to find in the province. And that's because there's no specialized clinic for lymphedema. Patients go to healthcare providers in different settings. Either it's in a surgical practice, a wound healing clinic, rehabilitation clinics, either in cancer centers or non-cancer centers, and many go to private clinics in which they pay for therapy such as massage therapy to relieve their symptoms. Therefore, they are somewhat invisible to us in terms of trying to identify who is a lymphedema patient. So to create a lymphedema registry, we wanted to create a network of care providers, patients, and caregivers so that we can identify lymphedema patients and ask them to consent to this registry through electronic forms and with a questionnaire. Then we would connect that information to their healthcare records upon their consent, of course, and therefore build this registry to identify who is a lymphedema patient in Alberta. More importantly, to my perspective long term, is that we also will connect them to future research in which we can identify patients that might benefit from any sort of clinical intervention that we would come up with in the future. But what would the registry actually accomplish? Our goal is to gain information on the prevalence of lymphedema in the province, get a picture of who a lymphedema patient in Alberta is, as well as get an idea of how lymphedema patients are being treated. Because as in the slide I gave before, lymphedema patients can be found in different clinics for different reasons, and they might be treated in different ways. But nobody really has a good handle on what is a lymphedema patient being treated with in the province. So we can collect that information. And then from that information, access these patients to conduct future research with whatever is possible so that we can, again, get to the point where we can improve the lives of these lymphedema patients. To this end, we are right now have ethical approval for the registry. I have started to collect names of people who are connected to caregiving as well as networks of lymphedema patients within Edmonton that we've already consented. And in the summer, I will have a summer student that will start to collect these consents and start to build this registry. On the scientific side, we wanted to answer this question, why does lymphatic damage lead to lymphedema? So as many people know, there's many different risk factors for developing lymphedema. But even if you have these risk factors, it's not a guarantee that someone will get lymphedema. We believe that alterations in the environment within the lymphatic tissue can determine or can describe as a microenvironment, can drive the development of lymphedema, and that these changes can be before or during and after damage that will allow lymphedema to be developed in some patients while not in others because of these differences in the environment in which the damage occurs. The hope is that by altering this microenvironment, we can reduce lymphedema in patients and maybe even prevent it in the future. So this is what we're trying to understand. I apologize for the scientific nomenclature in this diagram, but I just wanted to get an idea of the changes that happen in lymphatic tissue during lymphedema. In this case, it's secondary lymphedema. In the initial stages, the changes are in the immune system, where you have immune cells that come in and surround lymphatic vessels and cause changes to that lymphatic structure. At later stages, there is less immune cells, but we have more fat cells as well as the movement and disorganization of the lymphatic vessel itself, leading to fibrosis and other conditions that are associated with lymphedema. We were interested in understanding what is the microenvironment within this lymphedema tissue. And we were interested in looking at growth factors, oxidative stress, hypoxia, which is the lack of oxygen, as well as inflammation factors such as senescence-associated phenotype and fatty acids. So where are we? Well, we have developed a tail model of lymphedema in the lab where we will be able to cause damage to the lymphatic vessels without affecting the blood vessels. And this causes swelling in a rat tail that is very similar to some of the changes that occur in patient lymphedemas. And this changes, then we can track and look at the microenvironment within this model. So what have we discovered? First, we discovered that repairing damage in lymphatic tissue is impaired by oxidative stress. So there is oxidative stress happening in which there is damage to the tissue, and this we found in the animal model as well as in patients' blood. We also found that this damage to lymphatic tissue can be amplified by something called lipid toxicity, in which there is a high amount of fatty acids in the tissue that's associated with obesity and unhealthy diets that potentiates the damage to the tissue and prevents it from being repaired. Cancer-related lymphedema, the treatments, can also induce a permanent block in lymphatic cell growth. And this is essential for the repair of the tissue, because if the cells can't grow, you can't create new vessels, you can't create new connections to the lymphatic system. And we think this is through a process of both cell death and senescence that's occurring. And senescence is a block in cell growth. And we're using this through lymphatic cells that we have in the lab, animal models, as well as patient blood samples. So we're connecting all these together to say, does this make sense? Does this reflect what's actually going on in a patient? So what you might think is, okay, that's all great, but how can that affect how we can improve the lives of lymphedema patients? We call that translating the basic science from the bench to the bedside, or from the lab to the patient. So in the first one, having oxidative stress, we could potentially use antioxidants or anti-inflammatory agents within the lymphatic setting to reduce swelling and to reduce the oxidative stress, in combination with things that could be pro-repair, such as growth factors like VEGF-C. This is ongoing research that we will be doing in the lab in the next couple of years. In terms of lipid toxicity, this can be something that can be changed through diet or supplementation with healthier lipids that could potentially reduce the amount of lymphedema that a patient has over time. And finally, for the cancer treatments, in which you have blockage of cell growth within the cancer cells, within the lymphatic tissue, we can eliminate these senescent cells, which then changes the microenvironment within the lymphatic tissue to be pro-repair and therefore reduce lymphedema in the future. The reason why I have question marks on this slide is that all of this is part of future research that we're actively pursuing within the next couple of years. And with some luck, I'm hoping that I would be able to get it to the point where we could propose clinical trials where we actually would test this on actual patients. So in summary, my research program is trying to understand the microenvironment that promotes lymphedema, develop therapeutic strategies that can alter the microenvironment to promote repair and improvement of lymphedema. Knowing these microenvironment alterations, maybe we can identify lymphedema patients to a particular type of alteration in the microenvironment that could benefit from these therapeutic strategies. And as I said before, ultimately, our ultimate goal is to create clinical trials to improve the efficacy of lymphedema. Now, I couldn't do all this myself. I have a team of researchers who are research associates as well as graduate students. I have 3 graduate students working on this program. Lazina, who's a PhD student, Sama, who wants to transfer to a PhD in the lymphedema area. I have Jacob here, who's working on the lipid toxicity study, and Mimi here is working on the cancer therapies that are causing toxicity to lymphatic tissue. And Karina here is my research associate who does the animal models in the lab. And Dianne is the technician that kind of glues everybody together. So I like to thank the patients who donated their blood for my studies, as well as the University Hospital Foundation for funding, and of course, the Kipnes family as well. And I can take questions from anybody, and thank you for this opportunity.
Thank you, Dr. Gibson. We had a question from, well, first there was a question about the access to this after the session. So I will just answer that quickly and say this recording will be available. So I know a lot of people have contacts that will want to see this, so that will be available for you to share. And then we had a question from Dianne. Is this the work that is happening in Dr. Vonderweed's lab in Calgary?
So Pierre Reeves' lab, we collaborate with very extensively. We actually get cells from his lab. So he's working on an animal system of inflammation, but his focus is on irritable bowel syndrome and the effects of the lymphatic system and the effects of lymphatic contractions. So the actual movement of lipid through the lymphatic system. And so he's very interested in the role that oxidative stress plays in this. Nitric oxide is a oxidative stress component that's really important for lymphatic movement. So we're working really closely with him to see how his research can also inform us on what we're trying to do. But our research doesn't overlap. We complement each other.
Okay. So separate but related.
Yes.
Okay. And in terms of, you said that a student will be
Mhm.
gathering consent. Oh, this is actually related to Diane's question as well. So a student will be starting to gather consent forms and things like that. So for like the patients on the call or the therapists who have patients who might be interested, like how can we get involved to help, or when does that open?
Okay, I'm hoping to have this open within the next 2 months. We're kind of waiting for approval to have access to the medical records. Connect Care is the approval that we're waiting for. Once we get that approved, then we can start the process and we will start to reach out to people to try to get contact information so that if they want to participate, then we can start building this network.
Okay, so you would let us know and then we could
Yes.
let our network know.
Yeah,
So if people
absolutely.
don't hear through other means, they could hear through us. Okay.
Right. And you can always directly email me at the university. You can look me up on the Google and I can definitely connect you.
Then ask, where can you give blood for the research?
Yes. So we are open for blood from anybody, but the problem is that you're going to have to be in Edmonton for us to get the blood because for it to be scientifically feasible, we have to process blood within 2 hours of collecting it. And so if you're in other centers, it just takes too long for it to get to us to make it useful. So we have to have the blood within our area. We are trying to work with the group in Calgary to have blood collection there, but we're not there yet. So right now, if you want to give blood, you have to be in Edmonton in order to do that.
How do you sign up to do that?
You contact myself, and I will then relay that to my clinical coordinator who takes the blood and does the consent and does the processing.
Okay. Is there anyone doing similar research in Calgary? Do you have any affiliates in Calgary?
So there's no one doing exactly the same research in Calgary, but besides Dr. Van Weed, we have Shan Lau, who does research on the immune system in lymphedema, and particularly about why lymphedema patients get so many infections, and trying to understand how to better prevent that and to treat it. So she is very much in this space as well. And so again, we're trying to connect because we're on each other's committees for graduate students and developing the projects and seeing how they overlap. But right now, it's two separate programs.
Okay. So hopefully that answers both Herb's and Jennifer's question. Is there anything residents of Ontario can do to help? Because yeah, we
Oh,
do have
yes, I'm
people
sorry.
from all over on the call
Yes,
here.
I know. So originally, when I was looking at this idea of the registry, I thought of the people in Ontario because I'm also on the board for the Canadian lymphedema framework. And I took their expertise to say, could we have a national registry where we can include people from BC, from Ontario, from all over to get a sense of where these patients are? And what I was told was, and I kind of knew this, that in Canada, the healthcare system isn't one national healthcare system, it's 10 independent healthcare systems. And so I can't have access to healthcare information in Ontario if I'm in Alberta. And so it becomes very complicated and hard to do. And so I made a strategic decision to just focus on Alberta, get the information here, and maybe by knowing that information, it can maybe help the patients in Ontario because I'm pretty sure that what's happening in Alberta is similar to what's happening in Ontario. I hope that answers the question.
Right. No, you had to pick a scope and then the information
Yeah.
should be scalable to other places. That makes sense.
Yeah.
Yeah. Yeah, because we had a question about BC as well.
Mhm.
But yeah, everything that you would get should be able to be translated. That's true. And also, if you have success in building it, then the model that you use could potentially be used elsewhere.
Yes, absolutely. And also, as you said, like when we build this and have the information, I'm not going to hold it to myself. I'm going to share it with other people ethically with approval so that we would be able to build upon this moving forward. And so I think of the lymphedema clinics in Montreal and the databases they have there. That's something that would be able to connect in the future when we have enough patients collected.
Yeah, that's amazing. It's great to hear. I think a lot of people know that that's something that's very needed because, as you said, people aren't marked as, they're not coded as lymphedema patients. They're coded as cellulitis or
Yes,
wounds or whatever else. So
uh,
definitely important.
very true. Um, the challenge in this space is that everyone can agree that it is important and doing it, but actually getting the resources and infrastructure in place to do it is not trivial. It's very much the path less traveled.
Yeah, I think we were talking like a year and a half ago now about this, right? And you were trying to get the ball moving and everything, and it's taken this long to get to this point. So it takes a bit.
It takes a bit.
Um,
I want to do it right the first time, and I don't want to get halfway down and figure it out that I did something wrong and have to go back because that's not going to help anybody.
Absolutely. Jennifer said the Connect Care database system will be helpful, which of
Hmm.
course, yeah,
That is.
definitely. Howard, any suggestions for lymphedema self-care? I think that wouldn't be necessarily your realm to comment on,
Not yet. Maybe in the future I will be able to comment on it, but not yet.
right? Because we don't have conclusive. We're still waiting for the results.
Yeah. I'm a
Right.
couple of years away from
That's
that
okay.
translation bit.
There's progress, there's hope. That's what we care about. Excellent. Okay. Any other questions? Do you have any closing remarks that you'd like to leave us with? Not to put you on the spot, Dr. Gibson.
Um, I'd just like to thank everyone for giving me this opportunity to talk to you. And I'm hoping to connect with the lymphedema community more in the next 2 years with this registry study, as well as with our biobanking in order to promote this. And when we get to the point, and again, hopefully a couple of years in the future, that we can actually create some clinical trials, that we could generate some enthusiasm through your network so that we can connect the right patients to these types of studies so we can do them as quickly as possible. Because one of the challenges is when you're doing a clinical study, and other people have had this issue as well, is recruiting patients who are eligible for these studies into the studies within a fast enough period of time.
Yeah, it's all decentralized, people recruiting from everywhere. So that would definitely be very helpful. And sorry, there is a very good question in the chat. One more from Fran about your primary question being directed more towards secondary lymphedema. Do you anticipate the findings to be informative for primary lymphedema?
It could be important for primary because at the end of the day, it's dysfunction in lymphatic function. The reason I was careful about not talking about primary lymphedema is because it's an inherited genetic condition that develops in lymphedema over time. And so the microenvironmental conditions associated with that would be different because it is a genetic disease. And so maybe we will get to that point to have questions associated with that, especially if we have issues with any type of these mutations being associated with what we're doing. And if that is true, then we definitely will go into it. But we made a concerted effort to focus on secondary lymphedema first, and then go to primary lymphedema later on. I haven't ruled it out.
Amazing. Okay, well, thank you, Dr. Gibson, once again for joining us, and thank you everyone for joining us this evening as well. Be sure to check out the other events that are upcoming on our website, and we will be sure to keep you posted as to Dr. Gibson's research and when you can get involved.
Thank you. I appreciate this.